Hi class, welcome to this online session. We are going to discuss today on the breast pathology. So we have a total of 7 slides, starting with slide 73, that is fibroadenoma, followed by 186, that is fibrocystic change of the breast, 212 sclerosing adenosis, 185 invasive ductal carcinoma, 217 Pagets disease, 218 invasive lobular carcinoma, and 221 medullary carcinoma. So our first slide is slide 73, which is fibroadenoma. This is the most common benign tumor of the female breast. Okay, so its counterpart, if you're going to talk about the male breast, would be the gynecomastia. So this is a stromal tumor, which would mean that majority uh, of its composition would be mainly the stroma. It is fairly circumscribed. Okay, so when we have the gross specimen, it would be nodular and it is gray-white in color. And then histologically, we would see the presence of a lot of this stromal component. It can be fibrocollagenous, it can be fibromyxoid like this one, it can even be fibrohyalinized. And there are two patterns of the stromal component. It can be the one that would encircle or surround the individual ducts and ductules, which we would call as pericanalicular, or it can be distorting ducts and ductules in a sense that it will be forming slit-like structures. This would be the intracanalicular pattern. So the ducts and ductules here would be normal looking in the sense that it would be composed of ductal epithelial cells and myoepithelial cells. Okay. So with the category of breast lesions, this would fall under the proliferative changes without atypia. Okay. Our next slide is slide 186, which would be fibrocystic disease or fibrocystic change. This would show a triad of histologic components. We have the presence of cysts, this one, that wherein the ducts would be cystically dilated. Then we have fibrosis, and then adenosis would be the other one, wherein we would see the presence of ducts and ductules. Okay, so grossly there can be the presence of cysts because of the dilation of these ducts. They would appear to have a blue color appearance. That's why they are called blue dome cysts. The fibrosis in fibrocystic change would be attributed to the rupture of some of the cysts, causing the leakage of the materials, the secretory material, into the adjacent stroma. And then we have the adenosis, which would mean that there's an increase in the number of the acini, or the ducts and ductules per lobule. This particular breast lesion would fall under the non-proliferative breast change. Okay. Next, we have slide 212. This is called sclerosing adenosis of the breast. So this would fall under the proliferative breast changes without atypia. Okay, so without atypia. This is a variant, okay, of the fibrocystic change, but there would be an increase or marked increase in the number of the ducts and ductules, similar to that of the fibroadenoma. but the ducts and ductules here would be surrounded by a lot of this fibrosis, to the point that sometimes you would confuse it or mistake it with an invasive ductal carcinoma. However, the ducts and ductules here are well formed, okay, and they do not invade into the adjacent stroma. So this is sclerosing adenosis. Okay, so just make sure that you would be able to differentiate this one from the invasive ductal carcinoma. Okay, so again, you can see well-formed ducts and ductules separated or surrounded by fibrocollagenous stroma. There. Okay. Okay. Next slide, we have slide 185. Okay, this is already a malignant tumor of the breast. This is what we call as the invasive ductal carcinoma. Okay, so just a reminder, you have to differentiate this one or distinguish this one from the previous slide, which is 212, that is sclerosing adenosis of the breast. That particular slide is benign. This one is malignant. Okay, invasive ductal carcinoma is a form of breast cancer that comprises 2/3 of breast malignancies. In the WHO classification, it would be termed as NOS, or non-otherwise specified type of breast malignancy, or it would also be called no specific type, okay, because there are several variants for breast carcinoma. With regards to molecular classification, we would use the three immunohistochemical markers to differentiate the different variant, the different types. So we have the estrogen positive, HER2 negative types with low proliferation and high proliferation. So this is the first molecular subtype. The low proliferation of the ER positive, HER2 negative would comprise 40 to 55% of all cases. And then we have the high proliferative, which accounts for 10% of cases. How do we differentiate the low from high? We use another immunohistochemical marker, that is Ki67, to highlight the proliferative index. So that's ER positive, HER2 negative. That's the most common molecular subtype. This would be followed by the HER2 positive subtype, which would comprise 20% of cases. So it would mean that HER2 would be positive, ER may be negative or positive, as well as the progesterone. That's the third assay that we use. 50% of these cases would be ER positive, so it means that ER negative would be the other 50%. And this is associated with p53 inactivation in 50% of cases of familial breast cancer, that is HER2 positive, ER positive. And then the last subtype, so meron tayong ER positive, HER2 negative. We have the HER2 positive only, okay, or HER2 positive with ER positive. And then the last is the triple negative, wherein the ER or estrogen is negative, progesterone is negative, and HER2 is negative. So what is the significance of having this particular subtypes? So it would be helpful to the clinician or the oncologist as to the type of treatment that particular patient would need. So if they're positive for estrogen, they would be given hormonal therapy, that would be tamoxifen, and it would be effective for them. However, if they are negative for estrogen, it is not effective for them. On the other hand, HER2 would mean that additional drug should be given to the patient, okay, in the form of trastuzumab, and that would be effective for HER2 positive, although there have been cases of resistance to trastuzumab. Okay, um, and then we go to the histologic grading of ductal carcinoma. We base it on the Nottingham score, Nottingham. What is this? We have the three-tier classification for Nottingham score. You have the grade 1, 2, and 3. And this is based on what we see histologically, the presence of tubular formation. If we see a lot of tubules, it's well differentiated type. We see the presence of a mild to moderate to marked nuclear pleomorphism, and lastly, the appearance or presence of mitosis. So if the cells would happen to have um, mild nuclear pleomorphism, it should mean that they are fairly uniform, absence of mitosis, uh, presence of tubule formation, it would be grade 1. Okay? Uh, if we do not have mitosis but have marked pleomorphism, no tubular formation, that would be grade 2. And if you already have all of those three criteria present, then it would be grade 3. So the histologic appearance the of of the neoplastic ductal cells would be that they are thrown into nests like this one. Okay. Sometimes they can be seen in cords. Let's try to see cords. Here, if you notice, you see a lot of the stromal reaction, and it's important for you to differentiate this one from sclerosing adenosis, because these are all uh, dense collagen. Okay. Okay, some of the cells would be thrown into cords like this, okay, or this one. Okay, so this is invasive ductal carcinoma. Okay, invasive ductal carcinoma. Next, we have slide 217. This is Pagets disease of the breast. So this is at the area of the nipple, and Pagets disease is characterized by the presence of unilateral erythematous eruption and crusting, unless we have bilateral uh, breast malignancies. So usually it's unilateral. Okay, so this is a rare variant of breast cancer wherein it arises most often from a ductal carcinoma in situ, and it would go into the nipple skin through the uh, sinuses, okay, without invading or infiltrating into the basal lamina. So that's why when we are going to look for those cells, they are located within the epithelium, into the stratified squamous epithelium. So these are the cells. Okay, so you do not see them infiltrating into the dermis. Okay, so let's try to look at them at a higher power magnification. Okay, so these cells are large cells. So you can see the presence of the Paget cells within the stratified squamous epithelium. So they have large nuclei and moderate cytoplasm. So sometimes they would have the perinuclear haloing. So this is another one. And then you have here a cluster of Paget cells. This one is another Paget cell. Okay. So if we're going to test for the immunohistochemical markers, usually they are estrogen receptor negative, and HER2 positive. Okay. And then next we have slide 218. So this is invasive lobular carcinoma. Invasive lobular carcinoma is the second most common type of malignancy of the breast. Make sure that you would be able to identify the cells because they are very small. This is associated with CDH1 loss of expression. If you remember CDH1, it's associated with the diffuse type of gastric cancer. That is the one that would cause linitis plastica. So invasive lobular carcinoma would be characterized by infiltration of atypical lobular cells. So these are small cells that would form the so-called Indian file formation. So this is an example wherein you have the single file formation of the atypical lobular cells. Let's try to look for other Indian file formations so that you would be able to understand. Okay, so here you have another set. Okay, you have here the single file formation. Okay, so this would be what we call as the Indian file formation. Another one so that you would be able to remember. Okay, here. So this is the Indian file formation. Okay. So it's not in the book, but that is the one that we use to characterize or identify or classify that it is an invasive lobular carcinoma. Okay, in the book it says the presence of a signet ring appearance. Okay, so that is another form of identifying the atypical lobular cells. But in the slide we do not have the signet ring appearance. What we would see would be the Indian file formation. Okay, this one. Okay. Our last slide for today would be slide 221, which is medullary carcinoma. Medullary carcinoma is a variant of breast carcinoma, which is characterized by the presence of nests of or aggregates of atypical cells. Okay. So these are all atypical cells, although it's not very clear in this particular magnification, surrounded by lymphocytes or lymphoplasmacytic infiltrates. Okay, high power magnification, here you would be able to identify the presence of atypical cells. And then adjacent to them would be the lymphocytes. Okay, so the lymphocytes here would be part of the criteria for diagnosing medullary carcinoma. Without the lymphocytic infiltrates, it's not medullary carcinoma. So this would be called an invasive ductal. Okay, so this is a BRCA1. Usually it is triple negative, and they would be fairly circumscribed. Okay, and this would confer a better prognosis than the NOS or the non-otherwise specified ductal carcinoma. Okay, again, these are the atypical cells showing to you moderate nuclear polymorphism, presence of mitosis. Okay, here you would see the presence of mitosis. There. So mitosis, mitosis, mitosis. So you have a lot of mitosis in this particular tumor, okay, but this would confer better prognosis than that of the non-otherwise specified type of breast cancer. So those are the slides that we have for breast pathology. So I hope you study, because I'm not sure when this is the community quarantine would be lifted. So just study and study. Stay safe and good night.